Good morning and welcome to our monthly webcast. This is session number 29. I am sure you've all returned back to your cardiac cath labs from the TCT conference. I found it extremely educative, particularly in areas revolving around structural heart disease, and we'll even get an update from Dr. Sharma as to what is happening with particularly TAVI at Mount Sinai Hospital. In the meantime, I also want to thank so many of you who gave us some excellent feedbacks on our webcast. In particular, I'm even more grateful to some of you who have offered suggestions. Please continue to make it a part of your educational rendezvous, and hopefully you'll continue to give us your feedback. We have another exciting case today, a severely impaired LV function and a complex coronary lesion, and we'll show you the use of left ventricular support devices. But without any delay, let me take you to the cardiac cath lab where Dr. Kinney and Dr. Sharma are there. Samin, good morning.
Good morning. Look at.
I passed by your schedule, and is it correct that you have 3 TAVI cases scheduled today?
Well, that is true, and actually I'm so sorry, but just have to admit first, being delayed, because one of the case, we actually have 3 TAVI scheduled.
One of the reasons I gave that introduction is amongst the suggestions, people did mention that your cases don't necessarily start at 8 o'clock.
Yeah. Well, I mean, I would say that I take the 100% blame. I know no excuse for it.
I think you also get most of the credit for doing an outstanding job also.
Yeah, but clearly the lateness has been a kind of Achilles heel for me all the time, but we'll change it. And I really, that will be my New Year resolution for 2012. And part of that little delay occurred because there was some issue with one of the case of our TAVI with a core valve. This patient has a direct aortic access. We are going to do it, so the little logistics took me about 5-10 minutes, because while we are here 1.5 hours, 1 hour plus, that patient will be ready by the surgeon in the OR for TAVI direct aortic access, because patient has no subclavians and femoral. But with that note, I welcome.
But it is true that you have 3 cases scheduled for today?
And we have 3 cases scheduled today, yes. And we have 2 or 3 for next week. And so, knowing that the core valve having a 2 arms, extreme risk group and high risk. Extreme risk group was about 490 cases. That will come to conclusion within few weeks, so that all extreme risk will be completed. But high risk, just like what happened in partner B and partner A, will continue subsequently, and that probably we should close by May of next year. So having said that, once our core valve extreme risk closes, FDA, we are expecting FDA will give us will allow us the enrollment in the registry, ongoing registry basically. And of course, the newer generation core valve with a large size and small size and low risk patients will continue to involve more and more cases. As far as the clinically approved Edward Sapien is concerned, we wanted to wait till we complete the extreme risk group of the core valve, because I did not want to dilute our efforts into this major trial which we have been doing. And of course, the clinically approved Edward Sapien we expect to start in our cath lab by January or maybe February after completion of the core valve extreme risk group. The second issue with the structural heart disease, which was a lot of focus in the TCT, was the mitral clip. As you remember that the data of the E-valve is almost 2+ years now and has been with the FDA. FDA is still taking a little stand on it and not approved. There were some issues with the clip also, but they have resurrected now, and the new improved clip, because in the past there was issue with the detachment or not able to release it and requiring surgery, all have been taken care, and now under the Abbott sponsorship, that E-valve has been reintroduced in Europe. With that note, I think the structural heart disease will continue to take a forefront in coming years in our interventional cardiology.
Samin, in the meantime, I am able to report to you that we have 33 sites, most of them international, on live at the moment. Good. And most of these sites have somewhere anywhere between a small group to extremely large groups.
Absolutely. Now, with that note, I think we can start our case quickly, because there is a lot of required devices point of view in this particular case, and we'll try to show as much as possible hands-on and live performance of the procedure. Now, this patient is a 72-year-old female with progressive dyspnea on exertion and crescendo angina. Patient was catheterized actually should be October 14th and revealed mild pulmonary hypertension, minimal AS and 2 vessel CAD and ejection fraction was 25%. Now, at that time there was a lesion in the RCA very significant, got the Promus stent, and patient still continues to be symptomatic, is on good medical therapy, and we'll just show you the angiogram basically, but low ejection fraction with syntax score of 21 and mild aortic stenosis gradient was about 15, so the valve area came out to be about 1.8. And present our goal now is the PCI of the LAD diagonal bifurcation, actually kind of D1, D2. It's not a true trifurcation, but it's a bifurcation lesion of the involving both D1 and D2, calcific, and because of LV dysfunction, use the Impella Assist Device. So basically, inappropriateness, this patient because of high risk and on maximum medical therapy or dual anti-ischemic therapy makes it A. Now, Anu will take us quickly with the angiogram.
So we can see the LV is between 20-25. She actually had ischemia both anterior as well as inferior area before her first cath. And if you can see here, when she came last time, she had an RCA stent placed proximally, which is patent, and this is our site today. If I can just show you, is a short left main, and this is the JL40, which selectively engages into the LAD. And if you go to the cranial view, proximally about 50-60%, and just at the level of the septum is where the tightest lesion is, moderate calcium, about 80% lesion there. There are two diagonals, one at the level of the lesion, again a moderate size diagonal with the angle, but then there is a diagonal proximal to that, again at the ostium. If you see, it's a short ostial lesion, about 60-70% disease, and it's a large bifurcating diagonal, and entire LAD after that is angiographically disease free.
But look at the calcium. If you just stop that pause, look at the border of the calcium. Extensive calcium, the vessel size is so far almost the half of the lumen we see. There is a calcium outside, so heavy calcium in this particular case.
So, I mean, you didn't think in this particular view that the left main is significant?
But point is the left main just a very short.
Yeah, I think if you go, this is what happened.
Yeah,
see, my catheter was selectively engaged in the LAD.
Yeah.
So that's why you look like. But if you see here,
so
when you pull back, there is no left main disease.
What was your thought process in doing the right coronary artery first, a more severe lesion?
Yeah, that it definitely was a ulcerated and much significant lesion. It was 90+%. Here angiographically, you could say, well, it doesn't look that bad. It just calcific, but 60-70%. But clearly, that these kind of maybe 60-70%, but at the same time, it's a large vessel, and the patient's symptoms are progressive shortness of breath and with LV dysfunction. Then other issue comes that how do you account that LV dysfunction? Is it from coronary artery disease or so? It's very tough to say. Aortic stenosis is not a factor, and this patient actually a few years ago had a normal LV. So could it be related to that vessel, the LAD lesion which we are seeing was more significant at some point and recanalized or some remodeled, and so it's all possibility, but clearly it's there is no other cause in this particular case for LV dysfunction cardiomyopathy.
And the important is there was ischemia in both territories, not like any infarcted areas.
So based on that, you don't feel any need to proceed with the FFR evaluation for the LAD?
I think what we would need to do is at least do an IVUS to make sure that those two areas are significant.
So Anu, what would be your technical challenges, the pearls which you give us for this kind of a case with severe LV dysfunction and calcified LAD bifurcation?
Yes, so the EDP in this particular patient, EDP is just around 18 to 20, which is a very important reason. I think when you have LV dysfunction, use of Impella it probably helps us to to get a good result, angiographically good result when you are doing this kind of a complex intervention. Now the question comes is a patient has aortic stenosis, and the same, she had a aortic valve gradient just about 20 with a mild pulmonary hypertension and a good cardiac output. We got a valve area of 1.5. So the recommendation is the same between mild to moderate, where the valve area you can go up to 1.2 or so. Impella can be used. The question is when it's severe, when you have a valve area of less than 1, that's the only time I think it's a true contraindication, or if you have severe AI. Mild to moderate is okay, but if you have severe AI. So since she falls into mild to moderate aortic, I would say more of a mild AS, in this case we can use Impella. In this situation you should still use over the wire. There was no evidence of any peripheral vascular disease in her. We have the angiogram that is here. The second question will be
therefore basically what point you are saying is mild aortic stenosis Impella is okay.
Yes,
if you need it for LV dysfunction, that's it.
Yeah, but less than valve area of less than 1, that's the only contraindication.
Okay.
And the second will be, you have seen this again angiographically, LAD, just by looking at it we may think it is not significant, so confirm it with IVUS, but more important I think there is a significant calcium. So we document that, and to have a good expansion we may have to do rotational atherectomy. But the more other challenging question here would be how to handle this bifurcation, what we say. Second diagonal is almost 111, and the first diagonal would be probably, we would say 101. That how do we tackle this? Do we tackle with the rotational atherectomy and a single stent, or do we need at least one stent into the first diagonal?
Well, you have a task ahead of you, a complex lesion with the plans for IVUS, Impella. Samin, what are the
I think I will we can show the Impella insertion.
Yeah. So I think quickly if we can show Impella insertion, and while they're doing the IVUS and taking the angiographic views, I'll make my presentation.
So I also believe you have a new console there with the equipment.
Yes. Yeah, but that is actually have made our life so easy and simple. Readout console. So now Anu has already put a JR catheter into the ventricle.
Yeah, and now if you see here, very important thing, since it's a 13 French sheath, pre-close is a must. If you see our, this is the initial picture done. If you see there, and then 2 pre-closes have been done with the 13 French sheath already in. So make sure you have this C loop.
Yeah, wire getting to the apex is very crucial for all these procedures, including TAVI. The whole half of the science of the TAVI is that where is your wire into the ventricle, and that actually directs where your valve will be placed.
One of the interesting thoughts at the last meeting came out that TAVI looks to be 80% of peripheral vascular disease and 20% interventional cardiologist. Is that your thought too?
Yeah, that is true.
If we can show here, right?
Most of the case, the work is done just for getting the access.
All the complications are definitely related to the periphery.
Absolutely.
Yeah. So if you can see here, I think the one of the issue with the Impella used to be how you go with the wire and your exit point had to be just above your motor at the right point, and that is where we used to have trouble in getting. We had to make a bend at this level and make sure your exit point is at this black line. So what they did was they have this new orange color insertion for the wire, so that we don't have to struggle.
That's important. Otherwise, you need to push it to get it to the point and so. But now it gives you the direction. You put into there.
Put into the orange.
Yeah, whether it's more easy or difficult, but because many of these cases, like this case, was the different.
So
because
what will happen now? It will come out this small tubing, and the exit is easy.
Good.
and at that time you just take out this orange tubing. We have given angiomax ACT of 320. So as long as, if you are using heparin, as long as we know ACT is about 250, we can have the Impella insertion into the body. And if you are planning to leave it for a long term, as long as we are above 180 is allowed.
Such a small improvement to make, but it makes such a big difference at the exit point with that wire.
Absolutely. I mean, there is no question about it that Abiomed, they continue to improve the device in various ways. They have not stopped making changes.
So I am having no resistance in going through the aortic valve.
So
once we know we are in the apex, I am just going to take the wire out and see it will sit like a pigtail, and now the console will tell me is it okay or no.
And this is all there is to the insertion of the Impella.
Yeah. That's it.
Even with the current console, since they, if you see here, it's all color coded and they have written where what goes where. So it's very easy preparation. It takes less than 3 minutes.
Anu, you allow your fellows to place it?
Oh yeah. Fellows do this. They independently do this.
Well, the next question is, will you allow your PA to put it? How hard does that look to be?
Well, that will be hospital
based policy,
based
really
policy.
very user friendly.
Yeah. Very user friendly, but here you know, there are few things, hospital regulations, rules, regulation, you have to go with it. If we can just show the new console there,
which is easy for transport also. I mean, it helps you to transport if you need to. Although we are not done in any of peripheries, they do have rare case centers do have the balloon pump, but majority of them they don't even have balloon pump, so let alone being the Impella. But key is that overall easy in the transportable equipment now. And
you're already up to P6.
Yep.
You can see the new console now, right?
Yeah, everybody's seeing.
So that's okay, good. Show the picture where it tells you which part, or go to the display. You do it.
Yeah, and it's
so
telling
it will tell you. It will tell you exactly if your insertion is okay. So it says Impella position okay.
Looks like they.
As long as you can read English, this will tell you what to do.
they've been inspired, I think, by the
Maybe
iPhone
we need a different language too. Spanish and.
Yeah. So basically, I just Impella. The question then comes is, and that is the whole concept was of the balloon against balloon pump, because balloon pump is very well approved. They have, I would say, grooved into our interventional cardiologist in high risk cases. And the question was that can you replace those cases where you use the balloon pump to the Impella? And that I would say what has been the focus. I know anything else? While you are getting ready, I'll just go through the slide.
So we are gradually increasing. How far are we? We are at P6, which means up to anyway up to 2 liters. We will go up to P8, which will give us a 2.5 liter support now. They keep gradually increasing it.
Anu, how much is the LV EDP?
EDP was 18 to 20.
Are you also putting in routinely a Swan Gans or?
No. That was part of their Protect trial, but we don't do that routinely. Only thing I would say is, for some reason patient is on good medical therapy, good diuretics, and if your EDP is less than 15, 14, you should give some fluid bolus, otherwise you may have a negative suction effect.
And are you doing always a mandatory LV assessment by 2D echo prior to the procedure? Or?
Has to be, though, means if a part of the trial was that you cannot have, one of the definite contraindication is presence of LV thrombus. So if it's elective, we do it. Question is, in the emergency situation, we have done a couple of cases of cardiogenic shock and acute MI, where you have anterior wall, big anterior wall MI, your blood pressure is in the 80. If you want to do in that situation, we have done in emergency situation without an echo.
So the real issue is going to be what happens to, if anything, with the intra-aortic balloon pump, but it has clearly eliminated tandem heart?
I would say so, and that actually leads to our presentation while the Anu is getting the guide. And actually, you want to show that calcium right now on the angiogram?
Yeah. Okay. Go on, Cine.
Yeah. Sure. Yeah. Look at the LED calcium. So heavy, which we call tramp track. that you can outline the vessel, so heavily calcified LAD. I'm sure that will be confirmed on the IVUS. So coming back to the point that what do we do and where do we use of the three of the hemodynamic support devices, the balloon pump, PTVA and Impella recovers 2.5 or the 5 which is the surgical cut down and so. But basically we are talking about everything percutaneous. So much so with all the percutaneous valves, and so we are talking how we can go percutaneously. And I'll just try to share the latest data on balloon pump and on Impella, and clearly knowing that there is not much for the PTVA, and your question comes is very timely. That is that if what will be the condition where would you use a PTVA over Impella? I would say precisely the two situations which we discussed today. One, there is a bad LV, but patient has LV thrombus, and you cannot use Impella. I would say that will be the one case. Second, the patient who has severe, moderate to severe aortic stenosis, that may not be or severe AI, may not be a good case for Impella. Having said those two conditions, if you really need to go, and I can tell you in the Mount Sinai, we used to use PTVA about same 1.5 per month, kind of 3 every 2 months in the beginning. But since Impella came, we were a little skeptical whether it will be as effective as PTVA. But clearly we have our own data published in CCI that despite more complexity of the patients, lower ejection fraction in the Impella group, outcome was similar. And of course the time to insert was much lower. So if we can come back to, so that PTVA, because it requires multiple punctures, you are going to have a large arterial, venous, and then of course transeptal, so that those may increase the total procedure time and potential complication. As you know, the balloon pump, the latest trial which was just presented, CRISP AMI, the patient with anterior STEMI without shock, those who have 2 millimeter ST elevation in 2 contiguous lead or total 4 millimeter ST elevation, and the plan was that balloon pump prior to PCI or PCI stand alone. And of course some cases were crossover will always occur, about 8.5% of cases. But the key was that after in the patients, the PCI group, you put a balloon pump before and leave at least for 12 hours. But although majority of them were left for 24 hours. The primary endpoint was cardiac MRI done 3 to 5 days post PCI. Purpose is to see myocardial salvage, and then secondary also primary endpoint were basically the in-hospital event and the TIMI flow and clinical events at 6 months. And this paper, after initial publication in European Society, published in JAMA, and overall showed that in the CRISP AMI trial, use of balloon pump was not associated with reduction in infarct size, which was the primary endpoint. Rather, it was non-statistically or trend towards higher infarct size rather than lower. So basically, from the primary endpoint, balloon pump did not work. But where did it work? Basically is, you can see the individual 30-day endpoints, that there was statistically lower, although non-significant, I mean numerically lower, non-significant mortality, of course slightly higher stroke rate with the balloon pump and higher vascular complication. But there was, we see a little trend towards lower mortality with the balloon pump group. More importantly, once you get a 6 months data, things become slightly favorable, that in the sense that patients who have a non-statistical alone are again the trend toward lower mortality with the balloon pump PCI group versus PCI alone, and more importantly development of cardiogenic shock. As you see, that was the exploratory analysis, death, shock and newer worsening CHF was significantly lower at 6 months in the balloon pump group. So that basically what we learned, and now particularly now the data from the BCIS trial, and so elective cases maybe in high risk may allow you complete revascularization and so, but definitely there is no data to support that it reduces infarction. In acute MI setting, only thing I can say that it does decrease the occurrence of shock, so that in some selected cases balloon pump can be used. And of course the PROTECT 2 trial, now they are presenting some more new data. We already have presented these slides back in June, and clearly that what it did is that patients with Impella had a more aggressive revascularization, more extensive revascularization, or full revascularization with the various devices using rotational atherectomy and the more of the vein graft treated. That really led to actually some of the outcome difference, and overall the 90-day endpoint with the major adverse event as you can see here, that if you take per protocol or intent to treat, that clearly with the per protocol, those who received the Impella device had a from 51.4 went down to 40.8 at the 90 days. And of course, as you remember, the trial was prematurely halted. And of course, these are the data continue to show from the MAE point of view that Impella continues to better compared to balloon pump in the balloon pump arm. Now, where was the difference? 90-day outcome, as you can see here, that clearly individual endpoints, which are of the total 9 endpoints, that overall the difference basically occurred in a slightly higher the myocardial infarction, but more significantly lower repeat revascularization. And that was a very, very important endpoint, that decreased repeat revascularization in the Impella group, because allowed us to do a complete job in these patients. And of course, atherectomy and not atherectomy, the same issue was that yes, you have higher CK release, but at the same time, you had a more complete revascularization even in those patients with atherectomy. Now, and this actually boils down to that overall, when we talk about the patient, we talk about the total cost. If your patient comes back and you do an incomplete job, and it's even if the cost was initially higher of a device, that you pay more. And that actually was clearly shown in the PROTECT 2 trial, that the 90-day outcome, if you take all patients, all cost, which was presented in TCT, that largely because you decrease the revascularization by half, significant lower revascularization in the Impella group compared to a non-Impella, the balloon pump group, 12.4 versus 6. And you can see here, it translated into, despite the higher cost, still numerically lower dollar cost at 90 days of all hospital charges. And basically, this graph actually shows that yes, Impella is the device which increases the cost, but also improves the quality of adjusted year of the life. So that quality of life years, that yes, it's an expensive device, but at the same time in these high-risk patients, it improves the overall quality. And as you can see here, green bar compared to the our other left ventricular assist devices, and so where the DRG comes down to for Impella, that we are still far lower than more advanced devices for overall improvement and the financial cost savings. So it seems to be the device is cost effective and of course decreased revascularization. Now this actually also has been incorporated in the latest ACC AHA guidelines now, that class 1 for the cardiogenic shock with the hemodynamic support, whether it's a balloon pump or Impella device or in tandem heart, actually they just use the word overall the LV Assist devices are used for this purpose, so that patients with cardiogenic shock we can use it. Although as you know, there is yet data from any device, whether it's a tandem heart or it's a Impella or it's a balloon pump, showed that the significant difference, because the balloon pump is routinely inserted in these patients, and we don't have any clear-cut trial for the cardiogenic shock. Some small data there, but everybody believes that you need a support and cardiogenic shock, and therefore the use of the LV Assist devices are become a class 1 indication. And class 2B is the percutaneous hemodynamic support devices, that elective insertion of an appropriate hemodynamic support device as an adjunct to PCI may be reasonable in carefully selected high-risk patients. Level of evidence C, as like this particular case, based on the PROTECT 2 trial using the Impella device. And lastly, that yes, now we can transport these patients on the devices, but I can tell you nobody is going to use Impella for transport. If we can use a balloon pump, will be great. Although many other devices, cardiopulmonary bypass like LifeBridge and so, are being introduced and investigated for that purpose, that you transfer the patient on the full cardiac cardiac life support. Therefore, if you come back to our graph, which I used to have in the past, I have modified it very clearly. Clear in the sense that patient with a good ejection fraction, which you call more than 35%, that you need maybe a balloon pump in those cases. But once you get to the PROTECT trial, the patient population, EF of less than 35%, many of them EF of less than 20%, that clearly, if your complex PCI, your high syntax score, your high STS of more than 5, if you require extensive revascularization, Impella is your device. That will decrease your subsequent revascularization and will be cost effective despite your 19,000 more cost of the device compared to Impella, compared to balloon pump. But overall, the patients will do better on long term with a lower MAE, major adverse event. Now, of course, if the ejection fraction less than 20, many of these cases are inoperable. Syntax score is 50. I can tell you every other week with the case we send to surgeons, but they decline and they send the case back to us largely because of it's inoperable because of comorbid conditions. On those cases, Impella. And I just put a PTVA in those two rare situations where there is a significant aortic disease or LV dysfunction. So that to sum up, that enough data to support now based on the guidelines as well as the data from the trials that patients with high in a cardiogenic shock, hemodynamic instability or high risk PCI, Impella gives a very good support. It's safe and effective for us to do a PCI and more complex multiple revascularization, extensive revascularization. That's actually part of the trial by the data from Jeffrey Popma was also that patients with extensive revascularization will do better with Impella versus low revascularization. Now then second issue becomes is the lot of data on the on-treatment platelet reactivity and the outcome. And basically we call it a OTR. Patients are taking antiplatelet therapy. What should be the cutoff? Traditionally we have had 230 as the cutoff. Remember the Gravitas trial, which overall was negative in terms of a double dose versus standard dose clopidogrel. But if you take a PRU, platelet reactive unit of the ACE of Acumetrics, if 230, actually if you take a double dose, higher percent of patients of course will get your PRU of less than 230 compared to standard dose. But if you take a 208, and why I'm talking about 208 seems to be the data supporting now that 208 is our new platelet reactivity unit. That is why, because of course it has been shown that primary endpoint, this is the paper came out from the Gravitas sub-study published in Circulation, that if you have a 230 cutoff, it does not make any difference. Remember all the cases in the trial in the Gravitas, the patients who have more than 230 PRU were randomized to a high dose or standard dose clopidogrel, but only once you cut it down to 208, there is a difference becomes significant. So the 208 seems to be a better number of the on-treatment platelet reactivity. This also goes back to the latest presentation by Greg Stone of the ADAPT DES in the TCT, which was a large scale prospective multi-center registry examining the relationship between platelet responsiveness and stent thrombosis after DES. And it was about close to 10,000 patients, and patient had IVUS and virtual histology. But more importantly, that they have a follow-up, and the follow-up platelet aggregation was done in these patients after depth loading, and very important. And these patients have various other assays were done. And basically this is the incidence of stent thrombosis. As you can see that overall stent thrombosis was 0.46. Definite or probable stent thrombosis occurred in 30 days in all these patients. And if you go that what is the criteria, that what is the odd ratio point of view, it's the PRU of 208 had 74.4% of cases in the definite stent thrombosis versus 42% of cases in no definite. Other inhibition came out to be a platelet inhibition of 11%. So the PRU unit of 208 and inhibition of 11% based on the latest data shows to correlate with overall outcome. And it becomes very important that patients with in ACS versus non-ACS, that in ACS patients is higher stent thrombosis, the non-ACS is so small, 0.22. So basically we are talking about patients who are high risk for stent thrombosis, particularly acute coronary syndrome, will make sense to do platelet aggregation inhibition. So that my last slide on this is that data suggests on the on-treatment reactivity of the platelet that we more effectively inhibit ADP-induced platelet activation should reduce 30-day stent thrombosis when applied to large patient population. And that is why that we have the positive trial of both Triton as well as Plato. So the newer agent of prasugrel and ticagrelor by more effective inhibition are better, and that is one of the very simple reasons why they have lower stent thrombosis. And therefore, although the event you don't need to test in every patient, but particularly high risk patient acute coronary syndrome makes sense, and with the cutoff now being 208. With that note, I think Anu is ready now. She has done the IVUS, and we are ready to do the rota.
Excellent review, including the updating of the guidelines for the Impella as well as the importance of the new PRU number of 208.
Yes.
It's also, I heard that there has been a very large increase in the Impella use in electrophysiological studies, including for ablation, happening that way at Mount Sinai too?
Yeah, same thing, that high risk patients, particularly VT ablation. Vivek Reddy is the national champion and experience on the VT ablations. Those cases sometimes take up to 3 to 12 hours, and therefore Impella gives a great support for those cases. And coming back to us, we do about 20 balloon pumps per month and Impella about 2. But in my opinion, based on the data and overall experience now, I would say that probably soon may become even half and half.
Well, probably I think it is the cost-effective data also which will hopefully help you. Anu, tell us what you have found with IVUS.
You can see the IVUS. Yeah, let it play. Just show the bookmark. I think.
Go to the play. Good.
We don't need the whole thing.
Yeah. Good. Yeah. Now this is the IVUS distal, mid to distal LAD, and coming back.
Samin, what are you using more, the Boston Scientific
so now,
or the Volcano?
If you see here at this point, I think this is exactly where the second diagonal, we are looking at that. That's where your tightest lesion is now. Yeah. So it is not a deep, more of a superficial calcium. And this is the diagonal, second diagonal, which we saw. There was no osteal disease. Becoming more proximal.
A lot of calcium. I mean, many places the full arc.
Okay, this is again proximal LAD.
Yeah.
Good. But if you can go back to that bookmark which we saw, which was at the level of the second diagonal. Yeah, we got like a 3.2. So you're getting various between 3 to 4.2, 4.3, all through from the first subtle up to the ostium of the LAD. But if you see, there is calcium, superficial calcium, and almost more than 200-degree arc. So we have rotational atherectomy ready with the 1.75 burr, and this IVUS was done with the on the rota wire. So we used a fine cross and a fielder, then exchange it to the rota wire. IVUS was done on the rota wire, and we are ready to go in now.
Yeah, only issue remain here is that since the minimum is at least 1.74, that should you use at least 2.0 bar. I mean, you could make it a point, although 7 French 2.0 bar can go but little stiff. But I think this is the case based on the minimum lumen of 1.74 multiplied by 2.43, that maybe the 2.0 bar will be better. But even then, I say to a lot of people that many times, because of the eccentric cut of the calcium, as long as you have cut that interelastic lamina with the calcified, your vessel will expand. So you don't have to worry about that. Your burr has to be bigger than the MLD.
So even before proceeding, Anu, you think this will be a single burr strategy?
Yes.
Okay.
Yeah, likely single burr.
Yeah. I mean, now only question is if the 1.75 just flies and doesn't do anything, then do you need to then go with the 2.0? And 7 French will take 2.0 bar. I mean, that basically will be based on how much resistance we get. And the calcium, as you saw, that in the area of the bookmark was almost like not 360, maybe 340. But just coming back to the point, yeah, good. That the IVUS, we use a Volcano versus the iLab. Actually, 3 of our labs are fit with the iLab and 2 of them with the Volcano device. And we had 1 mobile also.
What would be the percentage of IVUS you are using in your PCI?
Yeah, I think the many of them are basically for determination of the lumen, and the adjunct one is the decision. The 2 things. I would say the decision to do the PCI versus the use adjunct to your PCI. I would say adjunct to the PCI occurs in a very small percent of cases in our lab. But decision to make a PCI, I would say about in 15-18% of cases, and because of looking at the intermediate lesion and the patient has a borderline functional study. but in about 5-8% of cases, we do use as an adjunct to the adjunct to PCI, that PCI results optimization and so. So now 1.75 has been done. It seems to go relatively simpler.
So two good runs, initial ablating one, a second possibly a polishing one. Anu, how do you think it's going to look?
I think it will be good. We just have to see, go with the balloon. We have a 3O 20 millimeter balloon ready and see if it expands well. Give me the run through wire.
Yeah, we'll get a 3O20 quantum apex.
And you are almost always going with the primary wire and then exchanging it with the rotub wire as opposed to?
No, I think depending on
anatomy.
the lesion length,
Okay.
and yeah, many times we go directly with the.
Anu, there is a question for you which has come to my attention. What is the single best lesson you've learnt about Impella use?
I think which patients I think really need them. If you have your EF less than 20, more important, and they have some mitral regurgitation, moderate to severe or even moderate, and those kind of patient, I think it's very important if when you're doing intervention, especially if you think it is left main proximal LAD, you need Impella support when you're doing, because every inflation gives you a pressure of 30, 40. When you know you have Impella, you can be comfortable and do a good balloon inflation as well as the stent deployment. So I think in that situation you definitely need.
Two more specific questions for you. Have you ever needed to switch groins while placing an Impella?
That is a very important question. I think a groin evaluation is a key. So if you are planning to do Impella, what we normally do, actually even in this particular patient, you can go to the contralateral side and then take a picture, and you know that even if there is some calcium, and we know that we can get a pre-closed device done depending on the size, as long as we know it is about your femoral artery and your iliac artery is not very tortuous, we should be able to get an Impella done. Also very tortuous aortic aorta itself, or a couple of cases we have even done with the aortic stent graft placed. You have the aortic stent graft placed. This device even negotiates through all those stent grafts. So have evaluation of the peripheral vascular disease, and we know that even mild to moderate calcium will be able to do pre-close, even if it's not a double pre-close, a single pre-close that you can do, so that one closure device, and the next time you can just hold the other one, you can hold the 13 French sheath. We've been able to get the Impella device in most of these patients.
Okay, what you just did, just
so what we have the rota wire already in the LAD, went with the side by side run through wire, and the challenging question which we had in the beginning of the case, we have two diagonals. So which diagonal we think we should protect? We decided we'll go for the bigger diagonal, which is the D1. D2, if you see, even on the IVUS there was no osteal disease, and it's a very angulated takeoff. Probably we leave it alone. Now we already have 3 wires. I think we take out the rota wire at this time out.
Anu, the other question which came is, what is your recommended anticoagulant strategy with the Impella device?
We've been using, other than in the PROTECT 2 trial, since the trial protocol was to use heparin, every Impella cases we have been using Angiomax, except the ACT with the Angiomax we keep it above 300. Their recommendation is anything between 250 above, you can place the device in the body, but since we use Angiomax, we are about 300 ACT, and we've done every our Impella case with Angiomax.
Ever had situations where you use the Impella beyond its removal in the Cath lab?
No.
No.
All of them you are removing right here?
We do removal in the Cath lab since I think most of our cases we have done.
Yeah,
even
we are not
even in acute MI cases, once we know that it has gone and EDP patient is doing good, we have taken out the Impella here. Most important reason, when you are using this device is a vascular complication. So if we already use a pre-close, it's better to be done under sterile condition in the lab. So you take out the sheath and do a post-close in the lab.
Yeah, there are some data to say that if you can leave it for extra time, would it help in the myocardial recovery, and so is a different issue. But I, again, and the data also that you could leave it for few hours, up to 5 days even, and so forth, but we are not left in any patient out of the cath lab.
So if you see here now, see how the balloon expansion is happening. I don't think we need any extra rotational atherectomy. The question was at this point, I think, which the point has been made even in our previous webcast, that he goes about 6 to 8, Dr. Sharma tries 6 to 8, and if there's no expansion at that low pressure, that time we would have maybe decided that we could needed a 2 over. But here I think we have very good expansion. It's up to.
Now, all these lesions actually expand very nicely at 6 to 8. Once it is, then you don't need to worry about going to high pressure, because as long as you can open it, and now you are going to put a stent, and of course the issue will come that if you cannot crack at a medium pressure, then you go to high pressure, cause dissection is a major issue. So now we are done, and then of course the strategy will remain.
Now if you can show the hemodynamics, when he's going up, just look at the blood pressure. She was running at 140, when he's inflating, it's going about 100.
Yep.
If the without impeller support, you would have gone 80.
Samin, I checked today, this is our, I think, case number 5 done with the severely impaired LV function with the Impella device, and to me the most practical aspect looks to be how much better the patient tolerates the point of ischemia at the point of performing these complex interventions.
Yeah. Now we are at 2.8 P8, right? We are getting 2.4 to 2.5.
Some plaque shifting in the diagonal there,
yeah,
or
which we expected.
Yeah.
Now we can just do a little cutting balloon of the ostium. Yeah, let's get a 306 flextome. Look at the ostial diagonal. Yeah, yeah, 30.
I think distal to the second
I
diagonal.
think that is just a wire bias.
Yeah, okay.
That's wire bias.
Yeah, I thought either
We didn't
that
go
or some
that,
spasm.
the question you put one long strand,
3.5 to 38.
38, one long strand, and cover everything.
Yeah. But let's do the diagonal first.
So we are going to do the atherectomy of the diagonal.
And as you know, the bifurcation trial, the only trial open is in US for the bifurcation, the Triton, and that basically uses the bare metal stent Triton on the side branch, and it has opens up in the main vessel with a very little metal, and then you put a DES in the main vessel, and versus your conventional therapy, and yeah, and those are the trial ongoing, and we are part of it, and that may tell that routine strategy of the side branch stenting, will it be useful or not. I believe it, particularly this is a large vessel, that these kind of cases, putting a stent, in my opinion, will be better.
3.5, no?
And
3.0, 3.038.
Okay, we can dial it with the 3.5 later.
Right?
Yeah, I was surprised you are deciding to go with the 3.0. My initial thought was a 3.5.
No, 3.5.
No,
Yeah.
3.5. But
Okay.
if you are, we are planning to use one single stent.
Right.
Down.
No, but I don't think it will be one stent case. Huh? No.
No, you could, if from the subtle,
Yeah.
all the way.
Will not be a one stent case. We can say, see this now. This was the balloon dilatation. Look at the length of the balloon.
That's 20.
Yeah.
It's
No.
20
And
there.
then we need to come very proximal. See, the
that's
lesion
all
is
you need.
lesion is all the way up to there. Look at the calcium. Yeah, lesion length to me will be at least 45 or so. So it will be okay that we use a 33 and then maybe a 33 and 15.
Okay, they are very important. Then you
3.5,
cannot
33.
overlap at the level of the diagonal.
Yeah, so in between.
Yeah.
Will overlap in between proximal, I mean.
Yeah,
Just
proximal to the first
D1.
diagonal.
Yeah, but let's see how the diagonal is first, because if in case there is a bad dissection or we are not able to open it
No, we
completely, we may need to stent the side branch. So this is a very big vessel.
Okay.
Okay. Yeah.
Looks all right.
Yeah. Looking all right. There is a little bit of dissection proximally, which we expected.
Samin, where do you think are going to be the future?
Quick. No.
Yeah, I'm sorry, say it again.
Where would the future applications of Impella be? Particularly, do you think it will have a substantial role in structural heart disease?
Well, I mean, it's the same thing. The question comes that there are some reports of using it in balloon aortic valvuloplasties and so, the question will be that which other patient that I still doubt. I think it will continue to be from our interventional point of view. Interventional, particularly the cases which are high risk and particularly those that have been declined by surgeons. So that to me will continue to be a more bigger area of growth of the Impella.
Now you use a very probably the world's biggest user of rotational ablation, and unfortunately, or just as a part of the procedure, I'm sure still continue to have some cases with no reflow.
Yeah.
How does the Impella compare with the balloon pump for no reflow?
Well, I mean, it's the key basically is based even on the PROTECT 2 trial data that what happened in these patients. Use the 3.5 15 Pro now. That in the PROTECT 2 trial patients, 15 Promus. Yeah, the 3 point the rotational atherectomy, but largely because that you do some CK release. If you make it an end point of just CK release, that you will have some issues. But our change, based on the data, our use of the Impella in rotational atherectomy has not decreased. Rather, most of the cases are like this, that we use a rotablation and in these cases. And that is, again, I would say the part and the overall, the slow flow or success rate, and so that clearly that there is no difference. It will provide, just like it will provide in any high risk patient, better support than balloon pump.
Anu, so you use that syringe to do a quick deflation?
Yeah. She's very symptomatic. As soon as you go up, her pressure is still dropping. Very symptomatic. Had to do a.
Good. Need to go proximal.
See, other thing that we can do in this situation is, use a half and half.
Think you'll need to do something at the distal side too?
Yeah. We just
that we can
balloon.
do a little more. Yeah. What happens is sometimes it's
but
lot
see
of.
The diag, both the diags look good. We don't have to do anything. We just take care of the proximal. We have a 3-5-15 ready. So now you got to go to the caudal picture, whether it's LAO caudal, AP caudal, RAO caudal. So before you open the stent, we have to make a decision. See, you can't see much in the RAO caudal. Maybe even when you move the, yeah. Question is 15
Catheter
or
may be
18.
too far down.
Yeah. No. Okay, now.
Pull back and counterclock. Yeah, the catheter is going more selectively because there is almost no left main.
You pull back and counterclock, so you get into the LAD. 3, 5, 15 should be good, right?
Yeah.
Now you have to take out the fielder wire, which is in the diagram. So it just comes out easy. What if the things goes down?
Okay. So we have removed it. Now we are putting a 3.5 15 Promus completed, because this was a long lesion, and of course I know the maximum will be 38 millimeter now. Ion is available and shown. The platinum element will be available, and so in the 38 millimeter, many times we may need even a longer, and of course those are cost effective because one stent rather than using multiple stents.
The TCT was all about structural heart disease and platinum stents.
Yeah.
You're a 15 mag? Oh, 20 mag. It looks so big.
Yeah, no.
Okay. Some down. Okay. Take a picture.
Anu, very instructive for you to have moved to the caudal projection here.
Yeah. So now see, if not, we would
Absolutely,
still
you would
here.
have,
See,
yeah.
little movements will just cover the circ.
Into the,
Now
yeah.
the very important point that we don't cover the D1.
Right.
We don't see the ostium of the D1 here.
You want to go other view?
Yeah, because that is
So
see, double stent will just jail that big
A
diagram.
little more than a one cell
Yeah.
overlapping.
Yeah. The question: did we have to go even to 12?
No, 15 will be okay. That's it.
Not getting the.
Will die. The diagonal is far away. See that?
Okay, now.
So as long as diagonal is away, let's go back to other view again.
Yes.
Yeah.
I think this is the only time that we will go to multiple views. But both of us, myself, Raksharma, we do not like moving views to views. You just stick to one view and keep finishing the procedure.
And this is okay if you want to put a wire in the circ at this point.
Looks quite all right there, the
Yeah,
positioning.
good. Go.
Yeah. But I would suggest that those who are trying in this situation,
Yeah,
that
not-
it's okay to put a wire in the circumflex
yeah.
at this time.
Down. So what I did was, once he was inflating, I pulled the guide out.
Excellent.
Yeah.
2 millimeter in.
Anu, if you can take a quick look, how much is the augmented pressure there with the balloon, with the Impella?
If we are with 140, when we are inflating, it goes down to 100.
Excellent.
Yeah, down. It's at 2.5 liters
Wonderful.
pH. Yeah. Now we can start going down. We start to wean.
How much has been your ACT during the procedure?
It was 320. Yeah. So at the beginning we gave, the patient is getting bolus, and here what?
Yeah, and we had mentioned, we have ordered the PRU, Acumetrics Verify assay now, and then we'll decide in this particular case that do you need to change it, since already a patient has been. So we did already.
Distal, we did
Yeah.
not know overlap.
So we may need another balloon. Yeah, fine.
Okay, go now.
Okay.
3.5.
Yeah.
Get us.
Yeah. We have
you have the
3.5
3.0?
balloon. Yeah, we
You
have 3.0 balloon,
Because
yeah.
distal,
Yeah,
what
yeah.
we'll need is
That
a little
massage.
bit.
Yeah.
See, other thing we'll do also is maybe just a lot of it could be wire bias.
And many times when your balloon, you want to advance distally, does not come, you bring back the balloon into the guide. It wraps it and then you are able to go back in.
So what you do is you pull back in the guide, it's rewrapped, and then you go. See that?
But yeah, but we don't, you want to go this
Go up,
further?
yeah, yeah.
Go a little further then. Distal.
Excellent illustration of exactly what you had just mentioned.
Yeah. And always the question is same, as far as possible, guide should be just at the ostium of the left knee. So we are not causing, with these multiple movements back, forth, that we are not causing more damage. I don't have to go distal. You need a 3.0 balloon.
Yeah, that's fine. That we can do.
Okay.
That we do.
Let's
Yeah.
take a picture. Same. We take first caudal picture. We make sure the ostium of the
Circumflex
LAD,
is
circ,
okay.
everything looks
Yeah.
good, and then we go to the cranial picture. Good. No pinch.
Everything looks very good there.
Yeah. So we go to the cranial. Make sure our diag is good. The distal little balloon.
Yeah.
Balloon.
Now, a lot of people are concerned about doing a balloon, but many times when you have this distal edge, it's not necessarily any dissection or so. It's just a vertical displacement of the plaque. So we have very low threshold.
Other thing what you can do if you don't want to is bring your soft portion and take a picture now.
No, but the other thing is your guide, fluoro. No, this one you need to see. Also remember the stent distortion, which has become, let's take a picture. Also it's become at the limelight that many times these guide catheters, these stents are very thin struts, and your guide may distort longitudinally the stent. So that this concertina effect, and so is very common.
Shortening of the stent.
Yeah, sure. With these guide catheters, so we have to be very careful with these new generation stents that we don't have. Good. Let's take a picture. Okay.
Go. See, it looks good.
Yeah, I don't think it needs
Yeah,
anything.
you don't need anything.
Yeah.
It was all wire bias.
Yeah. And all the branches, look at this.
The
Very,
diags.
very good. Yeah.
Both the diag good.
And with that note, if we can just go to the, coming back to the conclusion, we started 15 minutes late, we have finished 15 minutes late, and coming back to the very simple two messages of take-home message in this high-risk PCI with support and the platelet reactivity, just give you the latest data that Impella Assist Device used has shown to be safe and beneficial in high-risk complex PCI, achieving extensive and full revascularization, and has now become the part of our ACCHA guidelines also to use it in patients with shock as well as in high risk, respectively, as a class 1 and 2A indication. Second, the platelet reactivity testing on treatment may be indicated in patients with ACS, and new PRU cutoff is now 208, which predicts subsequent outcome. Yeah.
Samin, excellent case, wonderful review. Anu, what is any final thoughts from you as to what additional message people could take from this case?
I think same in this kind of complex. I think we showed that where actually Impella truly helps you. I think this complex case could not have been done without Impella, only because if you can just show the hemodynamics right now here is blood pressure right now is 160, and that's what happened with her 140, 160, and every time that we are inflating in the proximal LAD, since it involves so much of the myocardium, she goes less than 100, almost to close to 80 or so. So in this situation, we know that you have some your assist device, so you keep doing your procedure, not paying attention to the blood pressure. So we were able to get a good result, which is very important in this patient.
So the Impella comes out right in the cath lab.
Yes,
when do you
we
think
are now at P2.
When do you think this patient will be going home?
Tomorrow.
All right.
Tomorrow.
Yeah. We are going to do the pre-close. If you see here, the fellow George, who is with us, who got these two pre-close, if you can show here.
Let's bring it.
Right.
Yeah.
Okay.
Yeah, we have these two.
Yeah, you can start the
Weaning
weaning it out.
Yeah, we can just show you how we take it out. It's very simple, like you take out the balloon pump. They have two pre-close, which is on either side, the 13th French sheath. So once you know you inserted, you always put some towel, cover it so that it does not come on the field. We are now P2, good. So
it's off.
Nothing.
So now you can just pull it out.
Just take it out. So we can just show the fluoro. You don't even, if you can just see that, how it comes out. Yeah. Just take it out all the way down.
So you're not even using any wire to remove it?
Nothing. Just come out like a pigtail out. Yeah.
Okay. All right. So this way we conclude our this morning session, and as I said that we'll make every effort, unless some natural delays, that start exactly at 8 o'clock.
Which is, would that happen in December or in the new year?
Well,
December.
December, in preparation for the New Year resolution, I had to practice it to make it exactly at 8:00. That's a great ability, and from Dr. Fuster, his habit that I need to learn to be absolutely start in time, even if there are a lot of other things going on. The strategize things, although today delay was largely because of related to our one of the direct aortic access core valve case.
Anu, good, excellent demonstration, great technique with the Impella. Good luck also with your TAVI cases today. This has been another outstanding presentation, and I hope you've taken some learning tips. We'll see you back here again on December 20th for our session number 30. Till then, thank you so much, and please keep interacting.